So I've taken this patient's surname out to de-identify him. He's a 42-year-old male who presented to me because he's tired. He is a snorer, but his wife is nobly bothered by this. You can see in this field, this is our only free field in the software that we've developed. He's having issues at work with excessive tiredness. He's an engineer in the office most of the time, and he has moderate restless legs syndrome on International Restless Legs score. So his BMI is 29. He's filled out a 20-minute survey, and all of the questions can be seen here. But we don't need to go through all of the questions. We can, because we've summarised them in this area just here. Say, for example, if there is a partner in the bed, there is a partner icon. If the partner is bothered by it, it's in red, and there's the questions. He doesn't suffer any nasal obstruction, and there are the nasal obstruction questions. But say, for example, if he said yes, it would say, is it present or does it fluctuate? If he said it fluctuated, and is it mostly at night? Yes, and there's no allergies, it would say vasomotor rhinitis. But he has answered no, so those questions will disappear. His metrics are there. His BMI is 29. His Epworth Sleepiness Scale is 13, and there's his answers to the questions. His snoring severity scale is 4, and his functional outcomes of snoring questionnaire is 12.5, which means there is a significant impact on the quality of his life from his snoring and daytime tiredness. From this screen, we go to an examination screen, or we can go to the reports and we can have a look at the sleep study itself. Now, I'll just take his name out of that. And he has mild obstructive sleep apnea. In fact, he has hardly any obstructive sleep apnea at all. He has normal nasal airway, which is in keeping with his reporting no nasal obstruction. The technician has given their report, and we have the sleep summary and the respiratory statistics, and you can see that his apnea-hypopnea index is only 7. He has a relatively normal sleep latency and a normal REM latency. He didn't desaturate under 90% for any appreciable time. And that's called the T90, and that's significant when you come to talk about cardiovascular risk. And here's a hypnogram where he's rotating through the sleep stages. There are his REM periods, his body position periods, his oxygen saturation. You can see there's a little bit of artifact in that. He's a good snorer, and we can have a look at that, but then we go from the history into the examination. And again, these are all closed fields, and every bit of the examination has to be done in order to complete the software. So the modified Mallampati, his grade 2, his soft palate length was normal, his uvula length was normal. I'm just repeating what I put in earlier on today. So above this line is the examination without the endoscope, and here is the examination with the flexible nasendoscope. Nasal septum posterior was deviated right. He did have a spur on the right-hand side. He had no polyps, and so on and so forth, blocked on the right side from septal deviation. The turbinates were normal. We look at the retropalatal distance improving with jaw thrust. We look at the lingual tonsils. We look at the larynx and how it improves with jaw thrust. And then on Muller maneuver, we look at whether there's collapse in the hypopharyngeal tissues on negative pressure at the nose, and whether that collapse is circumferential or at the lateral ports, or indeed at the AP direction. This is for if there's complete obstruction and you'd like to see if it still completely obstructs with jaw thrust. This field is for any extra notes that you may wish to put in. So once we've got in our head the patient's desires, the sleep study results, the patient's history, the examination findings, we can then go and make a plan. So the significance of this plan is that it has to be as long and thorough as we can make it for the patient, because sometimes they will stop at point number 3 or point number 5 or whatnot. At every point along the way, there is multiple options for the patient, and in the form of all of these different things. From APAP trials to nasal decongestant trials to nasal valve dilators to night shift trials and positioning devices to a modafinil trial. So I thought that this patient would be worthwhile having an APAP trial, even though they had very mild obstructive sleep apnea. They are excessively tired, and it's worth a short CPAP trial just to see how much of their daytime sleepiness relates to that very, very mild obstructive sleep apnea. Once I saw him again and discussed this, I was thinking about a modafinil trial for his daytime hypersomnolence. For his snoring, I felt that a temporary oral splint would be of benefit to him, but we may need to follow this up with a conservative UPPP and tonsillectomy if it didn't quite pull the palate far enough forward. The patient, because he has a BMI of 29, would be a good candidate for a GP management plan, a dietitian, and an exercise physiologist. Now, that is printed up and given to the patient. Thanks very much for coming along. And this is our plan for you. And also, if there is a GP management plan available to be made for the patient, that can be printed up quite simply as well. There it is there. The software easily is able to be moved across to medical director or to best practice. And we do that by pushing print. So I'll just get rid of that. Let's go to a treatment plan. We push by going print and export, and then it's on the clipboard. You open up medical director and you paste it in. The only other thing that I want to show you today is that now that we have all of this data that's been placed into the software and at one free field, we can produce a report to the doctors who have referred to you. So I reviewed your patient, Jacob, today in my sleep clinic at Maloof Medical. His main reason for seeking consultation is that he's tired through the day. That's the only free field. We've extracted the data from all the rest of the data that's been uploaded, and there it appears in the letter, including the treatment plan and when the dates implemented have been done. So the idea of Sloom was to create a very standardized process such that every primary care physician is doing the same examination every time and hopefully coming up with the same conclusions. And what we're working on now is we're actually putting in a bit of logic behind everything that's put into the computer such that it can make suggestions when it comes to the treatment plan.